I would like to first introduce, and I'm going to apologize up front because I get her name wrong each time. She's told me like several times. Aurelie Ledreux.
Yes.
Aurelie is a researcher at the Knoebel Institute for Healthy Aging at the University of Denver. Her work focuses on healthy aging, on how moderate physical exercise can be beneficial to your brain's well-being, and more recently on studying biomarkers for mild TBI in college athletes, which I would love to hear more about at some point. So I'm going to let you go ahead and then I'll introduce Leighanna when it's time for her to go.
Thank you.
Thank you.
Well, hello everyone. Thank you for coming. It's my pleasure to be here today. So we're going to talk about aging and brain injury, and if at any moment you cannot hear me very well or you cannot understand me very well because of my nice French accent, please don't hesitate to stop me and ask questions. Also, I have to say I had a nasty cough for the last couple of days, so I hope that I will get through this. Okay, so today we're gonna talk a little bit about the aging brain and what changes happen as we age. We're gonna say a few words about TBI, so traumatic brain injury in older adults, and how it is different from TBI in young adults. We're gonna say a few words about how it is to age with a history of traumatic brain injury, and if there is an increased risk for Alzheimer's disease, for example. And finally, we'll talk a little bit about chronic traumatic encephalopathy, which is a neurodegenerative disease that happens after a history of repeated mild TBI. But let's start with the aging brain. So we know that there are structural changes happening in the brain as we age. And for example, in this graph here, you can see the brain weight as a function of age. And you can see that there is a trend, both in male and female, for decreasing brain weight as we age. There is also MRI studies showing that there is a thinning of the cortex as we age. And if you compare that young adult MRI here, you can see that the brain is plump and it's fully filling the skull, whereas on this 94-year-old non-demented person, the first thing you probably see is that there is an enlargement of the brain ventricles here, and there is also a thinning of the cortex at the outward of the brain.
I have a question.
Yes?
The chart on the left, I see the males are higher. Is that does that mean that means the loss of the nerve cell? They're like, I guess, more of a loss.
So that's a fact that male have larger brains than female.
Oh.
But don't make any, assumption on that. It's a fact. So we just have to live with it, I guess.
Okay, just curious. Thank you.
Okay, so chemical changes can also happen as we age, and there is a very well-documented age-related decreased production of certain neurotransmitters in the brain that may predispose to cognitive signaling, that may predispose to cognitive decline. So I won't go into details about that, but if you have questions, please ask. Vascular changes also happen as we age, and there is an age-related decrease in cerebral blood flow. Because of the loss of nerve cells and synapses, the brain atrophy can increase the space between the skull and the brain as we age, and so the blood vessels are more likely to be damaged during a TBI. So here is just something to kind of sum up what's going on as the age-related neurodegenerative complex takes place as we age. So aging is a multifactorial process that involves nerve cell loss, oxidative stress, reduced growth factors, protein aggregation, inflammation, hormone imbalance, and all of this leads to the age-related neurodegenerative complex that result in mood change, movement dysfunction, and memory loss. And I just want to point out that inflammation is something that is important in the context of TBI, because there is increased inflammation after a TBI in the brain. And as aging promotes chronic low-grade inflammation, that can be something that's more difficult to resolve after a TBI. I also want to say a few words about reduced growth factors. So you probably know that the neurotrophic factors in the brain promote neuroplasticity and help with the repairing after the brain injury. And as we age, there is a reduced growth factor production that can also affect the repair and after the TBI. So what is TBI? I'm pretty sure all of you know. It's the result of a bump, a blow, or a jolt to the head. And as you can see on this cartoon, the brain will hit the inside of the skull, and because the skull is not smooth and it's full of ridges, the hit can definitely damage the brain tissue, and also as the brain rebounds back in the skull, there can be some damage from the rebound as well. So here is just, I don't know if you can see that very well, but it's just an MRI from a patient's brain 19 hours after suffering a TBI from a fall. And you can see, I'm trying to point this, where is the mouse? Sorry. Oh, I lost it. Oh no, it's right there. Okay, so here you can see that there is some damage to the meninges, so that's the lining between the skull and the brain, and you can see from this MRI that there is some bleeding going on even 19 hours after the TBI occurred. So the symptoms of TBI, they can be both acute and chronic, and they fall under 4 categories: physical symptoms, sleep disturbances, emotional or behavioral symptoms, and of course memory, so thinking and remembering things. Physical symptoms can go from anywhere to headaches, migraine, dizziness, blurry vision, nausea, vomiting. There's also a lot of cognitive and physical fatigue going on, and there is also there can be extreme sensitivity to light or sound. Again, sleep disturbances can go for anywhere from sleeping more than usual up to trouble staying asleep. Emotional, people can become more emotional after suffering a TBI. They can experience sadness, anxiety, irritability. And there are memory problems associated with suffering from a TBI. For example, people can feel that they are slowing down, that they have difficulty thinking clearly, they can have difficulty remembering new information, and difficulty concentrating. So of course, in this range of symptoms, the severity depends on whether the injury is mild, moderate, or severe. And the changes can persist for months or even years and can significantly affect the patient's quality of life. So here is a very complicated graph to show you that the physiological consequences of a TBI are kind of complicated, and we're just starting from a research point of view to understand all the different processes that are taking place after the TBI happens. So it can take not only days, but months or years for the brain to be completely to completely recover and repair itself after the TBI. So in terms of epidemiology of TBI, we know that it's a significant cause of death and disability in the US, with over 5 million Americans living with disability related to TBI. There is about 1.7 million TBI cases per year in the US. And with regards to those 65 years and older, so in the older population, there is more than 80,000 emergency room visits each year after a TBI. 75% of these require hospitalization, and those 75 years and older have the highest rates of hospitalization and death. TBI account for 52,000 deaths in the US and is from about 1/3 of all trauma-related deaths in the US. So what is it to have a TBI in older adults? So how is it different compared to young adults? So we know from epidemiological studies that 85% of older adults' TBI are mild to moderate in severity. In majority, they are caused by falls, 51%, followed by 9% for motor vehicle accidents. Because older adults have more chronic health conditions such as hypertension, arthritis, diabetes, they are at higher risk for fall-related TBI. We know also from epidemiological studies that older adults with TBI have higher mortality rate compared to younger adults. And overall, we can say that it's harder for the brain to repair itself after a TBI. If you remember the schematic that I showed you where we had like nerve cell loss, all the phenomena that happen with aging can make the brain, can make that it's harder for the brain to repair itself. So in terms of cognitive dysfunction, we know that it's higher in older patients with a TBI compared to young ones. We also know that depression, anxiety, and sleep disorders are more prevalent in the older population. There is a research that supports the fact that moderate to severe TBI after 55 years old can predispose to earlier cognitive decline and dementia. We also know that there is a high variability in terms of cognitive decline among individuals, and that largely depends on the cognitive reserve. So the cognitive reserve is based on genetics, education, medical factors, daily activity, curiosity. It's basically your brain's ability to improvise and to find alternate ways to find a solution to a problem or to do new things. So the cognitive reserve is definitely very important in the recovery after a TBI. Overall, I want to say that there is only very limited literature available for the older population suffering from a TBI, and so more studies are definitely needed on this side. So how is it now to age with a TBI compared to having a TBI as an older adult? So I identified 3 populations at risk of aging with a TBI. The first one I thought about was, of course, the veterans. So the Department of Defense put together some numbers and showed that among the military personnel who suffered a TBI, 82% of them suffered a mild TBI during their active years of duty. Motor vehicle accident, already talked a little bit about that. I just want to point out that, during the young adulthood between 15 and 25-year-old, this is the time where there is an increase of people suffering TBI from motor vehicle accidents. And so that put this population at higher risk for developing, long-term consequences of motor vehicle accident-related TBI. And finally, we have to talk about high-impact sports. For example, football and rugby, because this is definitely a population at risk for aging with a TBI. And here in this graphic, you can see that the number of emergency room visits after sport-related TBI, this is, I think, annually, is higher for football players, and then basketball, which I didn't think about that, soccer players, and so on.
Question.
Yes.
Sport, is that boxing?
I guess that could be boxing and martial arts as well.
I just thought maybe boxing would be up there with football, but this.
Yeah. Well, there's people who actually box, so it's small. Right. Oh, sure.
I was surprised, for example, to see that golf is up there. But anyway. So in terms of aging with the TBI on the cognitive function, well, this study was published last year in 2017, and they compiled 45 research clinical studies looking at the chronic effects of TBI on cognitive impairment in people who had a history of TBI. And overall, they showed that there was a large proportion of people who were still cognitively impaired 1 year after suffering a TBI. And more precisely, they also look at people who suffered just a single mild TBI during their young adulthood. And they showed that, as the author says, that a large proportion of individuals with a single TBI will continue to demonstrate measurable impairment in various cognitive domains, including executive function, learning and memory, attention, processing speed, and language function, long after the initial injury, which is kind of scary, I think. So there is a lot of news and reports about, whether TBI would cause an increased risk for Alzheimer's disease. And I have to say it's very controversial and very debated right now. So I just put together some headlines of research papers that I found. So this one was published just a few weeks ago and clearly said that TBI history is associated with the earlier age of dementia onset when they did autopsy of people who suffered Alzheimer's disease. So essentially in this paper they said that people who suffer TBI develop dementia 2 to 3 years before people who didn't experience TBI during their adulthood. On the opposite, I found this paper saying that TBI might not increase the risk for Alzheimer's disease, and they based their analysis on 2 very large cohorts of people who were studied for the risk of Alzheimer's disease after TBI, and found that statistic evidence was not supporting the risk for Alzheimer's disease after TBI. But there is also this paper when they looked at 32 studies and definitely found an association between head injury and risk for Alzheimer's disease. And finally, this paper, which I think was very interesting, they want to investigate how traumatic brain injury can help solve the mechanisms behind Alzheimer's disease. So they mostly want to use animal models of traumatic brain injury to see how that could help, find answers to Alzheimer's disease and probably help with the treatment options for Alzheimer's disease. So just to give you a little bit of background of Alzheimer's disease, and if this is something that you already know, please, we can move on. So you probably know that Alzheimer's disease is a buildup of 2 harmful proteins in the brain. They are called tau and amyloid, and the accumulation and aggregation of these 2 proteins leads to the death of the brain cells and the loss of connections among them. So here is, for example, on the left, if I can find, here is a nerve cell, so that's a neuron, and you can see that it's full with the tau protein, which has accumulated and aggregated, and eventually this neuron will die as a result for the tau aggregation. And here on the right, you can see that these blue plaques, they're called amyloid plaque, and they are formed by the accumulation of amyloid beta, which is another protein. And when there is too much amyloid and too much plaque load in the brain cells also die, and that results in cognitive decline and dementia. So here is what a healthy brain looks like compared to an advanced Alzheimer's brain. And you can see here that there is also an enlargement of the ventricles here. You can see that there is some serious brain atrophy in terms of healthy tissue. And here is, for example, I don't know if you guys can see that, this is the hippocampus in the brain. So this is the part of the brain that deals with memory and remembering things and thinking and all of that. So here you can see in the healthy brain how it's nice and plump. And if I can show you here, this is what's left of the hippocampus in Alzheimer's. So you can imagine the damages coming from this atrophy of this specific structure in the brain. So finally, I think we have to talk a little bit about what it is to age with the history of repeated mild TBI. And of course, the example I took today is to talk about high impact sports players who are at high risk for repeated mild traumatic brain injury. And I think of course of boxers, as you mentioned, or football players. So this is what their brain look like after years and years of exposures to repeated traumatic brain injury. This is a normal brain here on the top, and you can see how it's plump and nice, and this is the result after many years of repeated mild traumatic brain injury. And you can see again that the ventricle here, if I can find my mouse again, here are much enlarged. You can see that all this dark thing here is tissue that is dead. You can see that there is a lot of brain atrophy. So you can imagine like what would be the consequences of living with a brain that is so much damaged from repeated mild traumatic brain injury. So I just want to take this example. I think it's a paper that I really enjoyed reading. It's about the pathology of traumatic brain injury in 202 former football players who died at the median age of 66 years old. And when they did the autopsy of these former football players, they found that 87% of them had CTE or chronic traumatic encephalopathy. This study includes high school football players up to NFL players. And I don't know if you can see that. Okay. So here is on the left a brain section, and you can see here that there is like a few brown spots. And these brown spots correspond to tau, so the protein that was showing you a few slides ago. So this is like a microscopic view of the brain, this brain area here. And you can see that there is a few tau tangles, but it's not too bad. So that's stage 1 of CTE. Stage 2, you can see that there is more brown spots, but you can also see that they mostly stay at the outside. So this is like the outskirt of the brain, and this would be the midline here. And you can see that there is more and more tau tangles. And in terms of behavior or cognitive symptoms, well, out of the 27 subjects that this study identified with mild CTE, they found that 96% had behavioral or mood symptoms, 85% of them had cognitive symptoms, almost 50% of them had motor symptoms, and 33% had signs of dementia. And that's only for mild CTE. If you look at stage 3 CTE, so here you can see that the tau is spreading like now towards the inside the medial temporal lobe of the brain. And of course you can see under the microscope that tau is everywhere, and it's even worse for stage 4 CTE. And in terms of symptoms, of course, out of the 84 subjects with severe CTE that they identified in this study, 89% of them had behavioral or mood symptoms, 95% had cognitive symptoms, 75 had motor symptoms, and 85 had signs of dementia. So I think it's very scary. And so just to summarize what we talked about today, Well, we saw that traumatic brain injury in older adults may worsen the age-related cognitive decline that happened with aging. We talked a little bit about the importance of cognitive reserve for faster recovery after TBI. So it's important to challenge yourself, learn something new, engage socially with people that you don't know, do something to keep your brain active, and always learn something new. We also talked a little bit about the link between TBI and potential increased risk for Alzheimer's disease, and we saw that it's still under study. We see that aging with repeated MTBI can increase your risk for developing chronic traumatic encephalopathy. And of course, something that we all have to keep in mind is that in older adults, fall prevention is the best way to avoid TBI, and I think the next speaker is going to expand on that in just a few minutes. So I thank you for your attention, and I'll take any questions. Thank you.
Okay, so our next presenter is Leighanna Konetski. Many of you probably know Leighanna as she works here in this building. Leighanna is a registered dietitian nutritionist working here at CDHS in the State Unit on Aging. She's been working in aging for over 17 years and is passionate about helping older adults maintain their quality of life and independence as they age. She's a Colorado native, how unusual, growing up on the eastern plains of Colorado, and enjoys spending time outdoors with her husband and her daughter. So perfect segue since you were talking about falls and fall prevention. So welcome, Leighanna.
Thank you. Okay. I want to talk a little bit about fall prevention, because one of the leading factors for an older adult to sustain a traumatic brain injury is a fall. And so we're going to talk about that today and talk about resources for fall prevention in the community. So I just want to do a little bit of background on falls. And
Can you speak up a little bit?
do I louder?
Yes.
That is the first time anyone's ever said that to me, but I'd be happy to speak a little bit louder. So I'm going to go over a background with you, basically what the State Unit on Aging is, because some of you may know about it, some of you may not, and then talk about falls, and then resources that are available in the community for older adults that deal with fall prevention. So our State Unit on Aging is in the Office of Community Access and Independence, and we're in this building located on the 10th floor. But what we do is we provide services to older adults throughout the entire state to maintain independence and maintain or improve quality of life. And so we provide services that range from transportation to Meals on Wheels, and we'll talk about that a little bit, but we do services for older adults for the most part in the community. So those older adults that are not institutionalized, so community dwelling. And we do that through partnerships with 16 area agencies on aging and over 200 provider agencies. We work collaboratively together, and it's something that's called the Aging Network to deliver services across our entire state for older adults. And so, like I just mentioned, some of the services we provide I think are very common household names, like Meals on Wheels. We also call that home delivered meals, but we do transportation, so we'll be taking older adults to the grocery store, to medical appointments, to senior centers, to lunch locations. We do family caregiver services. We strongly believe in supporting the family caregiver that's caring for an older adult, because we know if we give great support to that family caregiver, they in turn are able to give great support to that older adult and maintain independence. We have legal services. We have elder attorneys that we work with across the state that provide great resources, but also assistance, because a lot of our older adults are running into more and more situations where we're actually needing that legal or elder attorney advice regarding benefits, regarding tenant disputes, and so we have legal services. And then we have evidence-based programs. And the particular evidence-based program we're going to talk about today is fall prevention, but we also do a lot of chronic disease self-management, and we do a lot of medication management, nutrition education, and this is just a very short snippet of a list of aging services that we provide across the state to help older adults and their families maintain that support and independence for our older Coloradans. So what do we know about falls? Because like I said, that really is the main factor that's going to lead an older adult to sustain a traumatic brain injury. We know, and these are national statistics, and then we're going to drill down and look at what's the problem look like in Colorado. But about up to 30% of community dwelling older adults are falling each year. And again, community dwelling means non-institutionalized and non-hospitalized. So these are older adults that are just living in the community. So up to 30% are falling each year. Of those that fall, 20% are causing physical injury. And that's where you're going to see a traumatic brain injury. And that they are a leading cause of injury and death for older adults across the country. We know that really about a half to a third of those falls are occurring, around their own home. So they're not happening when they're skiing, they're not happening when they're hiking, they're happening in their place of residence in the community where they live. And they're occurring during routine activities. So think taking a shower, taking out the trash, changing a light bulb. So routine activities, sweeping the floor, that we do on a regular basis, and they are as well. That's where most of those falls are occurring. And typically, it's not just one issue that's causing a fall among older adults. It's like the perfect storm, because falls have a variety of risk factors that contribute to them. It could be a vision issue, it could be a medication interaction issue, it could be a chronic disease. And so typically it's a combination of things coming together for that particular older adult that's resulting in the falling. We also know, though, that a large proportion of them are preventable. It's not something that is normal to happen with aging, and they are preventable. And because I'm a dietitian, I always like to throw in, anytime I can, any nutritional impact. And I'm not talking about the MIND diet today, but there is emerging research that our older adults that are malnourished are actually at an increased risk for falls. And we know malnourishment in the aging population is on the rise, and it's undiagnosed. And so this also, I expect to see more and more research coming out talking about how this impacts our older adults' ability for balance and gait and other things like that, and it's impacting falls too. So here in Colorado, and these are from an Injury in Colorado report that the Colorado Department of Public Health and Environment put together, and their most recent one covered data times between 2012 and 2014. So these are statistics from our state. Again, just like in the national statistics, they're the leading cause of injury, death, and those over 65. And among those who passed away from a fall-related injury, 35% sustained a TBI, and 31% sustained a hip fracture. So if they are falling and they are getting a traumatic brain injury, there is a higher incidence of them actually passing away and having an injury death from that fall. When we look at injury hospitalization, or ED, that's emergency department visits. So not passing away, but injury hospitalization, emergency department, they're still the leading cause of that in the 65 plus population in our state. But of those that are hospitalized, 16.1% mentioned a diagnosis of a TBI, and 34% mentioned or had a hip fracture. And again, I think that goes back to the fact that if they are falling and they're older and they're sustaining a TBI, they tend to be more severe, and some of our older Coloradans don't live. So there's an obvious issue in falling in our state, as is across the country. And I didn't even go into the medical costs associated, are billions of dollars of healthcare costs associated, and the impact of quality of life for older adults, because many of our older adults, when they do fall and sustain an injury, don't get to go back home. They end up in rehabilitation, and then long-term actually end up in a skilled nursing facility. So in Colorado, we are addressing the problem through something called evidence-based programming. And evidence-based fall prevention programs are unique, and they are different than any other program for like physical activity or something like that, because they have evidence behind them that they work and there are sound outcomes. And so they have a stamp of approval because they've gone through research, we have outcomes, and they've been published in a peer-reviewed journal. And so we have science coming around these programs saying they work. When we implement this program and we implement it in the way that the curriculum and the fidelity are telling us to do, then we know we're going to see these outcomes. And I think that's very important when it has to do with fall prevention, that we want to engage our older adults in programming that has outcomes and evidence that it works behind it. And so we have a lot of evidence-based programming operating in our state for older adults, which is wonderful. We have the Stepping On program, we have Tai Chi, Moving for Better Balance. Not every Tai Chi program is evidence-based as fall prevention, and so that's one thing to take home to if you have aging loved ones. If they are looking for specific fall prevention Tai Chi, not every program is going to fit that bill. So this Tai Chi Moving for Better Balance does. We have another program called In Balance, and then we have a program called A Matter of Balance, and that program has an English language version, it has a Spanish language version, and it has a low vision version. And that's the program I'm going to highlight today. But all of these are great evidence-based fall prevention programs that are operating in this state. And so with any programming that is occurring in the community, really the only success for it staying long-term and lasting is really through teamwork. And any evidence-based fall prevention program can be expensive and difficult to maintain because you have trained facilitators that have to stay within curriculum and they have to go through specific training in order for that to happen. And our State Unit on Aging has been partnering with MindSource since 2009 to do A Matter of Balance, and we're grateful for that. That's MindSource is our longest standing partner with this program, and we've had great success with it since 2009, and it's because of teamwork with MindSource and lots of other those partner agencies in the community. And you'll see that behind all of the programming that's being offered and available. Lots of people working to make that successful. So A Matter of Balance is based on research at Boston University. Okay, and so they do research on a program to track the outcomes. They found that the outcomes were exactly what they wanted to see, and then they are able to publish in peer-reviewed journal and then replicate the program. So this is just some background information on Matter of Balance, and it has unique features to it. And every one of those evidence-based fall prevention programs that I was mentioning that are operating in Colorado kind of highlight and touch on different things. Because a risk of falls, like I talked about, is kind of like this perfect storm with all this stuff coming together for a person to fall. Well, there are a variety of risk factors that contribute to falling. And so the various programs touch and highlight different aspects of that. And Matter of Balance looks at fear of falling and increases physical activity level among older adults residing in the community. And you often don't hear about fear of falling as a risk factor for falling. But if you stop and you think about it, it is a huge risk factor for falling, because what tends to happen when somebody becomes fearful they're going to fall, they restrict their activity. When they restrict their activity, they restrict their mobility. And when they restrict their mobility, guess what? Muscles start to atrophy and they become more frail. And so fear of falling is in and of itself a risk factor for falling, and Matter of Balance looks at that. But we know that 1/3 to half of older adults acknowledge fear of falling. They acknowledge it. It's something that's talked about, it's something that's known, and it ranges in severity with the person. If they've fallen in the past, they may be having more fear of falling than if they have not. These are some of the bullet points that it's also associated with: fear of falling, depression, increased frailty, which I talked about, decreased satisfaction with life, and decreased mobility and social activity. That's that restricting that goes on. Oh, I can't go out because it might snow in 3 days. It may never snow, but there's a fear that it might, and so there's a restriction that happens where then the person doesn't leave their home for a week, maybe a week and a half, 2 weeks at a time. So it's a real issue, and Matter of Balance looks at that. So the program in particular is 8 2-hour sessions, and that can run 1 2-hour session for 8 weeks, or it can run 2 2-hour sessions for 4 weeks. And every program is different, and what they do is they meet the need of the community. Some people want that class twice a week for 4 weeks, some people want it once a week for 8, but the key is that it's 8 2-hour sessions. And they talk about learning to view falls and fear of falling as controllable. There's actual cognitive restructuring that happens in the program and assertiveness training that happens in the program. Participants learn to reduce environmental risk factors, which are a really big deal for preventing and reducing fall risk. And then exercise is a key component in every program to increase strength and flexibility. And we have had people come into this program that are in wheelchairs, and we have people that are not in wheelchairs. And so we are able to do the exercises seated or standing, and we do them at the level and the ability of the person. But often we have people coming to this program who really have been restricting significantly their interaction with life and socially and getting out because of a significant fear. And so they've done no physical activity. And by the end of the program, we're seeing them engaging more, setting goals, getting out, and increasing their physical activity and then continuing long term. So there's a lot of components that happen with every one of our sessions, but these are the keys. There's always group discussion, there's always problem solving, there's skill building, that assertiveness training I was talking to you about. We always do physical activity. We do watch some videos because sometimes it's interesting to hear somebody else talk about an issue that you yourself are struggling with. And then always are talking and sharing about practical solutions. So a good example would be a group of like 10 to 12 is our ideal size. And the person who's leading the class is not a teacher or an instructor, they are a facilitator. And that's key. So you're facilitating a group of individuals to talk about, with a curriculum, what are some of the issues surrounding fear of falling? And what is something that you're struggling with, or what is a concern that you have? And then it comes back to the group. It might be written down, and then the group might problem solve that to assist this individual, if the individual wants to problem solve on it. It's always left to the participant's choice. One of the classes and the sessions involves how to get up after you've fallen, and we have a healthcare practitioner come and talk about, you've fallen, what are the steps that you need to take safely to assess the situation, assess your body, assess if whether or not you've been injured, and how do you get up safely from that position in order to make a call and seek help. So the outcomes with a matter of balance. On the right side are comments that participants have made as a result of taking the class. And we don't expect to see outcomes unless they've completed the program. And remember how I said there's 8 sessions? We consider completion 5 out of 8. And the research shows if you get 5 out of 8, you're going to grasp what was intended with outcomes in the program. If you get 4 out of 8, no. So we count completion 5 out of 8. That's when we adhere to research with that. So these are the individuals that completed the program, and they're saying, I feel 97% are saying I feel more comfortable talking about fear of falling. Just being able to talk about something that you're anxious about and fearful of is a huge step in progression to dealing with that. 97% reported feeling comfortable increasing their activity, which is key because a lot of people come to the program and they have done absolutely no physical activity for a very long time. They plan to continue exercising, 99%. And then because of quality assurance, we want to know, would you recommend this program to someone else? Would you recommend like your loved one or a neighbor you know or a friend take it? And 98% say that they do. So one of the key things that we like to know is when you've completed the program, are you reporting fewer falls? And we are seeing our participants report fewer falls after taking a matter of balance. There's more information there, and I won't go through all of that. So who would benefit from this program? Anybody that's concerned about falls, anybody that's sustained a fall in the past, and in many of our classes we have many people that have fallen in the past. Somebody who's restricting activities because of concerns, anybody who wants to increase strength, flexibility, or balance. We do ask that they're 60 plus. They need to be ambulatory because we do exercise in the program, and they need to be able to problem solve because we do cognitive restructuring and we actually sit and we look at problems and we try to problem solve as a group, and we do goals and action planning. And an example of a goal in this program would be, I'm going to have lunch with my granddaughter. And we have many clients who have not been able to do that because of fear or restriction for years. And so the goal at the end of the program is for Sally to figure out how she can get down those stairs in front of her house, get into the car, and get into a restaurant. Those are real issues that we're dealing with on a regular basis in the community. And so they have to be able cognitively to problem solve. So this is what we have been doing in partnership with MindSource since 2009 and all of our other partners that I talked about. We've had 494 classes. We've seen 4,222 people complete the program. So I'm proud of that. It's near 10 years. It's been an excellent program. We have an aging quickly state, so our state is growing rapidly, and we always are looking for people to come into this program or any of the other great evidence-based programs. And typically in a year, so this was state fiscal 17, we have about 70 classes, and they're all over the state. They're not just in the metro area, they're in varying locations around the state. We had 755 people enroll, 618 complete. And so we can see anywhere between like 700 and 1,000 in a year. It was a milder winter this year, so typically our classes shut down because people will not go out if it's snowy or icy. They close at the beginning of November, and we don't see them opening up usually until April because people they're not going to come. It's concerning. And then so 8% of our participants report Hispanic Latino ethnicity. That's important to us. Are we reaching all groups in our state? And then on average, our participants are 77 years old, they're living alone, and they're female. So kind of the same things nationally, or the same things as some of the other outcomes. They feel more comfortable increasing their activity. That's a really big one to me, because if they come into our program and they've been restricting, when they're done, if they're increasing and they're going to continue, that's huge, because physical activity is a great preventative strategy for decreasing falls. Plus it helps with chronic disease management. It's wonderful. And so that's a fantastic thing. And we see 98% saying, yeah, I'm going to continue exercising. That's great. So these are some of the comments that our participants have made over the last near 10 years as a result of taking the program. I'm going to exercise more often. I have more confidence in myself, and I don't have the fear of falling. That's exactly the intent of the program, one of them. I'm going to remove my throw rugs. It seems so simple, but it's not that simple when you don't even realize that that is a significant contributor to falls around your home. So that's great. How many have loved ones that use the towel bar as the grab bar? That's pretty common in a bathroom. And so, I need to exchange those to have that bolted into the wall and secured in a way that I can grab it when I'm getting in and out of the bath. Improve my balance, ask for help when I need it. So those are some of the comments for the participants that have completed the program. And because I'm a dietitian, I always wanted to put, anywhere I can, put a little thing in there. But I do thank you guys for your time and your active participation today. Very much appreciate it. And we'll answer any questions. The cost of the program? All the classes that run through the Aging Network, there is no cost through our network. And here, I'll come back to this slide. It's small in the bottom, but there's this 1-800 number here, 1-844-COL-ADRC, and they will refer you to any evidence-based fall prevention program, including a matter of balance. And all of the matter of balances that run through our network, those 70-plus classes a year, are of no cost to our older adults because of funding and partnerships, and we want them to be available. That's part of the Aging Network through Older Americans Act services. And the thing about calling this number too, there may be other resources or services that you're interested in, and they will be able to help you find those too for your community. Any other questions?
Go back to the last slide so we can take a picture of your contact information.
Yes, you bet. My fruit question mark.
I love that. So cool.
I have to, when I could stick it in, I try to stick it in.
Where you find these
You'd be
things.
hungry with your slides.
Yeah.
There's your lunch.
I know.
Any other questions for Leighanna before we wrap up?
Thank you so
Okay,
much.
thanks everyone.
Leighanna, thank you.
Thank you, Chief.
Aurelie, thank you again for making the trip over from DU and sharing your knowledge. And thank you all for joining us. Hope you have a good rest of your day.